So I'm DJing here with like 2 computers, and we have a third one back there. So for folks coming in on either WebEx or Zoom, I honestly hope this works. We've tried really hard with a few dry runs, but we are in slightly uncharted waters. So we'll go ahead and give it a start. I'd like to thank Martha, first and foremost, for putting this together. She's fantastic. It takes a lot of effort and time, and could not do it without her. We also have Josh here from Terumo, who's helping to sponsor this event. Thanks, Josh. I get a lot of support from Terumo, nothing financially, unfortunately, but in terms of the clinical stuff, we have a really great partnership. And I was just telling them today about a patient who I saw in the office who has gotten some of these therapies, and he's sort of in tears because he's playing with his grandkids today. So it's all for a good cause. And we'll go ahead and get started. So what I'm going to focus on a little bit today will be cardiovascular imaging in the era of transcatheter therapies. A little bit of an alphabet soup, but some of these things that people might have heard of or come across: Tavr, TMVR, Tavr, a few other things. So we'll spend some time talking about, kind of what each one of those things are and, what they mean for us and our patients in June 2020. A little bit just about my story. I grew up in Boulder. I was a family full of lawyers, so I was a little bit of a disappointment. I spent a lot of time in Latin America and ended up doing all my medical school and training in Philadelphia. And even I was there for 15 years, but actually decided to extend that time to get extra training in aortic surgery and these transcatheter therapies. I started here in New Mexico in 2019. And, I think one of the real remarkable things is when I got here, I was giving these talks and it was all about what we had done in Philadelphia. And today is going to be all about what we've done in New Mexico in just this year. Brief outline to just let you guys know where we're going. I'll review a couple of the specific cardiovascular pathologies that kind of relate to imaging, transcatheter therapies, open therapies, and hybrids of those, and imaging modalities kind of in different episodes of care. So how we think about this differently if they're in the diagnosis phase, a surveillance phase, a pre-op, post-op, whether they're in the hospital, the office, a referring location, and then how these modalities might change depend on what disease or therapy we're talking about. With valvular disease, aortic stenosis has probably been the poster child of transcatheter therapies in the form of the transcatheter aortic valve replacement, or Tavr. Very disruptive technology, has completely changed the way we treat aortic stenosis. But like all of these, there will always be caveats. And in this instance, we're learning more and more that this has to do with the bicuspid valve patients. And this really hits home on our imaging and our diagnosis, because really this is all echo-based. And so, we really rely on good echoes and, to make that kind of diagnosis for these folks. Prosthetic valve degeneration. So folks who have had previous surgical valves or rings, this has been a real lifesaver, these transcatheter therapies. So people who had one heart surgery can now get another 10 or 15 years out of that heart surgery. We can go in and put a valve inside a valve. We can do this for aortic valves, for mitral valves and rings, and even tricuspid valves and rings. I'll take you through a case that we did here on that. Lastly, in terms of specific valve pathologies and transcatheter therapies, we do a lot of mitral clips for mitral regurgitation now. Again, these are all kind of depend on each patient, but I just kind of wanted to give an idea of some diseases and some therapies there. I am a heart surgeon, so I do a lot of open surgeries as well. And a lot of the kind of questions and referrals we get are, can you fix this with a catheter? And so there's a few things that kind of by and large are still all open heart surgery. The first one, like I said, is the bicuspid aortic valve disease. There's some excitement to treat these people with transcatheter therapies. A lot of controversy on that and some bad outcomes. And so open surgery for these folks is still tried and true gold standard. Aortic insufficiency, no transcatheter therapies currently exist that are FDA approved for aortic insufficiency. So by and large, we do that through aortic valve replacement, either with a tissue valve or a mechanical valve. You see those below there. Mitral regurgitation, still an operative candidate, best treated with an open repair. That usually involves something to stabilize the annulus, which you see there, which is that ring, and then eliminating any valve pathology, which you can see that valve sort of sutured up. Mitral stenosis, this was arguably the first transcatheter valve therapy with people who underwent balloon valvuloplasty. That has fallen by the wayside in the improvements in surgical outcomes and valve prostheses. So by and large, mitral stenosis, far rarer in the United States than in some other parts of the world, but we still see it, and still something we treat with open surgery. Tricuspid regurgitation, this is a hard one, for some of the referring folks, who have seen a lot of tricuspid disease be ignored by the surgical community. We take that more seriously now and try to be more aggressive on intervening on these people earlier. In the same lessons we've learned from the mitral valve, that if you let the valve destroy the ventricle, these people do poorly. And that was kind of what was done in the past and why people really shied away from tricuspid surgery. But we're trying to change that paradigm. Folks who have concomitant coronary artery disease, so by far and away, the most common operation we do are still bypass operations. So if you have any one of these valve pathologies and significant coronary disease, you're best treated through open surgery. And then aortic disease. So spend a little bit of time talking about aortic disease. The video you're looking at right now is of a type A dissection in the operating room. And that flap that you're seeing go back and forth with each heartbeat is the actual tear in the aorta. And if you look closely, I don't know if this projects, but you can almost even see the movement of like individual red blood cells. That aorta is so thin. So that's why we take these people to the operating room to prevent that aorta from rupturing, as well as other complications that come from type A dissections. In your upper right, you can see the basic classification scheme for dissections in terms of ones that involve the ascending aorta versus ones that do not. Where if you involve the ascending aorta, we do treat that as a surgical emergency. And if it does not, it was always treated with medical therapy, although that is changing, and we are intervening on those folks far more aggressively now with stent and transcatheter-based therapies. This is a little bit of what that looks like, the finished product. So folks who also have an ascending aortic aneurysm, by and large, get the same type of surgery, where we're replacing that ascending aorta with a Dacron graft to stabilize it from dissection or rupture. Like I said, the type B dissection, we've just had a few of those come in here the last couple of days. These folks we manage differently, particularly people who have the acute type B dissections. Historically, these folks got medical management because surgery was a big operation through the side that was highly morbid, highly fatal. Now, with the advent of transcatheter technology and the Tavr stent, which sort of borrows the EVAR, which was the endovascular repair of the abdominal aorta. The thoracic repair is similar technology. It's a little more complicated just because of the bends and twists that the aorta takes when it's in the chest, but it's really been a paradigm shift in terms of how we treat type B dissections. And these technologies are not mutually exclusive. So, what you're seeing here are people who have a combination of both open and endovascular surgery. And, the idea is, although operations through the front are big surgeries, it's a big recovery. I can tell you as an aortic surgeon that those recoveries are infinitely easier than operations through the side. And so what we're doing now more and more is operations that might replace some part of the ascending aorta and then allow us to come back with a stent graft that can complete that repair. So the heart that's beating here on the right is one of those operations. I'll kind of take you through that case soon.
So I was gonna have you do this one,
Okay.
and then we press with this one, and then we'll have.
Okay. Late breaking news. We're having some trouble with Zoom. Apologies. We will work on that as we can. So when we talk about interventions in imaging, these are intricately intertwined, and ever more so in the transcatheter world, because truthfully, that's what has made transcatheter interventions possible, is for us to see what we're doing without having to go through an open operation and do that in the traditional surgical sense. And then traditional angiography, including left heart caths and MRIs. So if there's, a fact that I can take, out there into the world, it would probably be this, is in terms of tell me something I don't know. So they did this study in Japan and looked at everybody who had an out-of-hospital arrest. And, traditionally what people are thinking about in terms of out-of-hospital arrests is, are heart attacks or arrhythmias, things like that. 7% of those people with out-of-hospital arrests were type A dissections. So that means, almost 1 in 10 people who come in with an out-of-hospital arrest are having type A dissections. For folks joining us from Zoom, I'll just repeat that I think one of the more important facts folks could walk away from today would be that there's a growing body of evidence that outside of hospital arrests really have to do with type A dissections in a way that we didn't appreciate before. Not to say that it's the majority of cases, but almost 1 in 10 of these patients have had a type A. So it just goes to show you how much we are missing these people when they're presenting to the hospital, in an arrest. So CT scans, really kind of the most important part of aortic imaging. When we're dealing with aneurysms, so, kind of take that type A dissection who probably had an aneurysm before they had their dissection, we want to get to them before that happens. And, in New Mexico and elsewhere, there's been a proliferation of CAT scans, arguably beyond primary care or cardiology subspecialty or CT surgery subspecialty practices. So, I really see scans as an important screening and an important referral source and an important point of access for care for our patients. So for the aorta, there really isn't any formal screening program for the general population in the same way that we figured that out for lung cancer. But I'll tell you, my clinic gets filled with folks who have aneurysms that are found with either lung cancer screening or calcium screening scores. And patients and myself are just so thankful that we're able to find this before it really becomes an issue. These are some of my own little rules about it, in a sense that, no harm and no contrast. So for folks who aren't really sure about what's going on, and you don't know whether to get a CT scan on the patient, it's not that the radiation dose is absolutely trivial and we can completely ignore it. But in terms of figuring out where these patients are and getting to them before they have their type A or before they have their out-of-hospital arrest, a non-con CT scan gives us a lot of information about the aorta. Not everything, but a lot to tell you whether this is somebody who needs close follow-up, more workup, or, perhaps just, they don't have a problem and they can kind of go about their life thinking other things. People ask me, when should you refer an asymptomatic patient? These are kind of my back of the envelope rules here. Any aortic measurement greater than 4.5 centimeters absolutely should come for a referral. Any aortic measurement greater than 4 centimeters with concerning features, so this is primarily people who have a positive family history, either of bicuspid aortic valve disease, sudden cardiac death, because again, we're appreciating those folks are dying from type A dissections, aneurysms in the family. And here I'll just be really clear and underline it. Whenever you don't like what you read or see, I can't tell you how happy I am to see somebody go through their CAT scan, talk to them about what's concerning and what's not, and I'm happy to provide that service. So, I would sort of say, really no referral, you know, for concern for aortic disease, I think is wasted. So this is somebody who came, a kind of quote unquote asymptomatic patient who had a cough. Actually they were traveling from New Zealand here, and they showed up, they're like, God, you know, I just got this cough. I'm from New Zealand. I don't really want to do anything about it. You know, but we got a CAT scan, you know, and really what you can see here is in that descending thoracic aorta, you know, essentially an impending catastrophe for this patient. But we were able to intervene. We put in a Tavr stent for them. They went home day 4, totally cured from this problem. Cough went away. Here's another one. So this was a lady who came for, she was found on a CT scan for smoking. And you know what you can see in here is that she has an ascending aorta that is not a healthy size. So that big circle there should be about 3 centimeters in her, and in her it was 8. So we did her repair in the operating room, and this is, you can't even, if you can appreciate this, you cannot even see her heart in her chest because her aorta is so big. Wow. And then in that same patient, after we took out her aorta and reimplanted all her head vessels and created a large space of Dacron to come in and put a stent later if we needed to, she did fantastic. And she's set up for any sort of future therapy of their aorta in her chest that she might need. So this is one. This is a guy who, true story, I actually saw in clinic today about 30 minutes ago. This was a guy who's playing with his grandkids. And so this was a kind of quote unquote type B dissection. And there's a lot of folks out there who have these type B dissections in the sense that they weren't truly in their ascending aorta. Really, they're in their arch. But these are not the type B dissections that start further down in the aorta. Arch tears really destroy the aorta. And what you can see on this guy on the left is his aorta is large. The normal part of it is way too small. It becomes this sliver as it goes down his chest. And we brought him for this therapy. You can sort of see the diagram of it in the upper right-hand corner, where first we did a surgical therapy and replaced his ascending aorta, rerouted all the blood supply to his head and arms, and then we're able to come back in with a stent graft and fix the rest of his aorta. And he's had a remarkable recovery. And then here I'll kind of transition a little bit in terms of where I see the interface between echo and CAT scans when it comes to aortic disease. For me, echo is a little bit harder in terms of making diagnoses for aortic disease. I like it because it doesn't have any radiation and there's a lot of access to it. But here's kind of a classic example where this was a 63-year-old lady. She had a bicuspid aortic valve. And really what you can appreciate on her echo is that she just loses that definition that she should have in her aorta, that it kind of just begins to open up. But then on the CAT scan right next to it, what you can see is that her aorta is really quite enlarged at about 5 centimeters. She also had aortic insufficiency, and then we found out that she had coronary artery disease as well. So for her, we were actually able to repair her aortic valve. We replaced her ascending aorta. We did her CABG. Like I say, I've only been in New Mexico a year, so I don't have 5-10-year follow-up for these folks, but I do have 3 months on her, and 3 months out, she's doing spectacular, but we'll keep an eye on her for many years to come. So a little bit more on this kind of, how do I see echo and CT scan when it comes to the aorta? I think the transthoracic echo is an excellent screening tool for aortic disease. It can be hard to reproduce the measurements. And sometimes people don't, their anatomy is a little bit off axis. So it can be hard to get those dimensions. You might want to be able to do it, but sometimes you just can't. So in my mind, it's always an excellent place to start. But if you're concerned, those folks kind of need to be taken one step further. The gold standard is really to get a CT scan with contrast. One thing that's a little bit hard is the prevalence of pulmonary embolism is also very real out there. I'm kind of an all aortic guy, but PEs are a real disease. And so we see a lot of these CT with contrast studies that tend to be looking for PEs. They're a little bit hard to evaluate in terms of aortic disease, but still not so bad. But if you're kind of just understanding how we really get an idea for it, that contrast has got to be timed for the aorta. When would I think about sending these folks? Here I'd be a little more conservative. So if you have any measurement on an echo of an aorta that's greater than 4 centimeters, I think it would be time to elevate that to some further concern. Now that might be a non-con chest CT, it might be a visit with myself or kind of somebody else who deals with aortic disease, but I don't think it's always a relief to folks. Or I could say this, that sometimes I feel like I have a strange job where people come to see me and they're most happy when they don't need my services. So when people come and see a surgeon and the surgeon tells them, hey, guess what, you don't need surgery, almost nobody walks away unhappy with that visit. So it's a big peace of mind to put this to rest for people. All right, I could talk about aortas all day, but I think that might not be everybody. So we'll kind of transition a little bit, talk a little bit more about the valve disease. So what does it mean? What does kind of structural heart therapy mean in 2020? What it really means is transcatheter therapy for valve disease. This is predominantly valve replacement therapy, which is real different than open surgery, which is either replacement or repair. The technology that we have the most experience with by far and away is the transcatheter aortic valve replacement, which is Tavr. We also do transcatheter replacements for previous surgical valves, for previous surgical rings, and we're doing mitral valve repairs in the form of mitral clips. These are all FDA-approved technologies. Tavr, I think most people are probably, of all the therapies, familiar with this one. It is a therapy for aortic stenosis. It is not a therapy for aortic insufficiency. It's best for folks who have sort of the traditional tri-leaflet calcific aortic stenosis. And what I'm trying to kind of show in these 3 pictures is why that's the case. So, the first one is a diagram of what these valves look like. The second is kind of how these technologies work. And really, it's a valve built on a balloon that we open up. And so it opens up in a circle. And if you have 3 leaflets, that circle opens up widely. And this technology works fantastically well. If you look at bicuspid patients, the geometry of their valve is just different. And this technology just wasn't built for these patients. And bicuspid aortic valve patients tend to present much younger. They tend to be much lower risk operative candidates. So it's a tough area. As a field, we're kind of figuring it out. There are some folks who do well with Tavr for bicuspid valves. And there's some folks who we really feel like it's more of a risk than the open surgery. And so we're sending those folks for open surgery. We do Tavr in previous surgical valves. Have to be tissue valves. It can't do it in the mechanical valves. But, I think of all of the technologies, the things that patients can really readily appreciate the most, patients who have been through the ordeal of open heart surgery is being spared that event a second time. And so I love this technology. I mean, it just means so much to these folks that they can get another 10, 15 years out of that valve. I hedge my bet a little bit there in that, we don't have follow-up on all these folks. It's a newer technology in a way. And so, we can't say everybody gets 10 or 15 years out of this, but, they get more than what they were going to get without it. I can tell you that much. And so the value to the patients to avoid a second surgery is really, really significant. We do it, like I said, for aortic valves. We do it for mitral valves. It's a little bit different. For mitral valves, we'll go up through the venous system, cross the interatrial septum, and it's sort of using the Tavr technology, just adapted a little bit differently to place these valves inside a previous mitral valve replacement if it's tissue or repair. So this was a case that we did here recently where we put the valve inside a previous tricuspid repair. The company was really excited. They haven't done a lot of these. They flew people out from Europe to sort of watch us do it, and kind of take you through each one of these images one by one. What you're seeing on the left-hand side, is the right side of the heart with the right atrium, the tricuspid ring, and then the right ventricle. The arrow there is pointing to where that ring has separated from the tricuspid annulus. So there's a leak around that ring. And then furthermore, that ring has kind of crumpled up. And so this patient actually has tricuspid stenosis. So what our plan was here was to put the valve inside that ring and then put a plug outside the ring to block the leak around it. So on the left-hand side, you see that valve going up. You know, this is what I was talking about, where that valve is literally a crimped up valve on a balloon. So
Now
they're
see,
blowing it up inside that previous ring.
You are
The
viewing
middle
Martha
shot is a
Mallory's
valve
screen.
fully deployed. If you look directly above it, there's a lot of wires and stuff. It's
My
hard to see, but
father.
there's kind of a haziness.
No,
That's the
your
plug.
message.
So the plug is there now, plugging the hole on the outside of the ring. And then there's an echo on your right-hand side, you know, which shows that valve functioning very well, no leak around it. You know, this was a patient who was not an operative candidate at all, was bedbound, and, you know, was able to go home in 4 days and is up walking around, you know, living a life that she didn't think was possible.
So you know the echo clips are showing like this instead of this. So tilt your head.
Interesting. Sorry, guys. I think on Zoom World it worked. The last transcatheter therapy I'll talk about here is the Mitral Clip. So this is actually a valve repair therapy. It's not approved for everybody with mitral regurgitation, so there's some nuances to it. But in general, I would say, you know, if there are folks who have mitral regurgitation who people feel like are not operative candidates, this is again a real groundbreaking technology for us to offer therapy to folks who we couldn't necessarily do it before. Similar to trying to replace the valve for the mitral, we go up through the venous system across the interatrial septum, and then this device is kind of like a clothespin turned upside down. It's honestly the size of a dime, as you see there. And the idea here is that we're just grabbing those two leaflets and bringing them together. And, you know, again, surgeons were really critical of this technology because it's so much less robust than an open surgical repair. But it can honestly make a big difference in the mitral regurgitation for these patients and a big difference in their quality of life. And they don't have to get through the therapy of an open surgery. And so that gets them a lot of benefit as well.
What's the name of it?
It's the same thing. It's a nitinol.
I have one open already.
And then it's the question for the Zoom and WebEx folks was sort of what the clip is made out of, and you can see it there. It's a grasper followed by, so it's like two clips that kind of each grab one leaflet, and there's some little jaws in there, and then they get made out of nitinol with a cloth fabric around it. And here's kind of a look at how this happens when we're doing this in real time. And so, you know, what you see there is, you know, in the echo, we have what would be our 2D from a transesophageal echo. But what we now use more and more, and what has really changed our appreciation of echo intraoperatively, you know, and in surveillance and workup, and particularly for this technology, is 3D echo. So these last two images on the bottom are 3D echo. And if you can kind of imagine, you're sort of sitting in the left atrium looking right down at the mitral valve. And here is that clip device that's coming up and over to grab those clips, or to grab those leaflets, sorry, with the clip and bring them together, kind of like how the diagram shows it on the right. So, you know, in terms of the imaging technologies that we've talked about, you know, from CAT scan to transthoracic echo to transesophageal echo, and then in the 3D echo, you know, is really kind of all of these, in my mind, have their own role. You know, the 3D echo is probably the hardest to get patients access to. You know, that's not readily available out there everywhere. But when it comes to being able to do these transcatheter therapies, we really couldn't do them without them. And so I'll kind of wrap things up on, you know, what does the future look like? The future looks fantastic. So this is hybrid imaging, you know, and this is kind of where we're headed in terms of being able to do these valve and cardiovascular therapies. It gets done in a hybrid room. And what we're doing then is you can kind of see this imaging is overlaying, and it's overlaying in real time. So you can get echo and fluoro and your device, points in space that get fixed, and you can see them on both sides of that. And so, I mean, it makes it, I'm not going to say idiot proof, but, it allows you to navigate in this world in a way that we never really could before. On the aortic side, where we're headed is stenting to the ascending aorta. So some people might have encountered people who had type A dissections. It is a disease that goes up with age. So we do see it in older folks. And there are people who oftentimes are not offered surgery because of their age or their comorbid conditions. This will be an absolute game changer for those people, to be able to put a stent in the ascending aorta. Currently under trials, nothing that's FDA approved. But here's where I have to be, in full disclosure. This is stuff that we haven't done here in New Mexico. Everything else we've done before, but we'll be doing this here soon. And again, kind of what can we do in terms of aortic surgery to treat these folks? And you can imagine what it might be like to treat this aortic pathology through open surgery. And we were able to do this just with stents, sort of small incision. People get out of the hospital and get on their way pretty quickly. Gonna open it up to questions, and we're gonna do our best to answer this in our Zoom world. Okay. Any questions in the room? I think, my takeaway on most of this is that we couldn't do the therapies that we're doing now without the imaging technology that we have. And it starts with echoes and CAT scans, for patients who either show up to the clinic or to the hospital. And then, I really see that as we build and escalate both in terms of our therapies and in our imaging, in terms of getting these people, from diagnosis to completed therapy.
So, when these steps, like the compassionate care, sometimes we might use the severe AR and Tavr. Are we doing any of those things or too much AR?
So the question was whether we can do Tavr for aortic insufficiency. It is not FDA approved. And so there's questions about whether to do that for compassionate care use. In certain selected patients, it's possible. The problem with that, and some of the things that I've seen, so that technology was built to grab that calcium. And so if patients don't have that calcium, I've seen people try to open up the valve and it just deploys into the aorta, and then it's a catastrophe. Okay, we got some questions. What are the post-op requirements for mitral clips? That's a great question. There really isn't a consensus on that. It depends a little bit on what to do with the patients who come in. A lot of these folks already have atrial fibrillation. And so, they need to be on either Coumadin or a NOAC for their atrial fibrillation. And then in those instances, we would also do an antiplatelet. If folks are not anticoagulated, then usually we do dual antiplatelet therapy for people who can tolerate it. But there's some debate in the community about that.
Do you have my page too?
There's another one.
I got it from the phone.
My question. So on the mitral clip surface, in terms of blood clot, being anticoagulated, have you seen any cases with blood clot for probably?
I have not seen blood clots on our own mitral clips, but they are out there. And so, so that's where people are kind of trying to still figure out best therapy for that. I think they need more than just aspirin at the very least, and then people go back and forth as to whether it should be aspirin and some kind of NOAC or Coumadin or aspirin Plavix. Fall risk, patient age kind of factor into a little bit. So it's not one formula fits everybody, but the thought would be similar to the repair, that you think over time that would endothelialize a little bit. And so the stroke risk, in theory should be higher earlier on. And so maybe, err on the side of more anticoagulation earlier rather than later. Yeah, so the question was about dental prophylactic for mitral clips, and they should be treated the same as anybody who has a surgical valve. So antibiotic prophylaxis for all dental procedures.
Dr. McCarthy, as far as the 3D imaging goes, is that something you'd like to see us do more transthoracic here in the clinic, or is it something you're relying on just for transesophageal?
So the question was whether we can do 3D transthoracic. I'm greedy, I'll take it if we can get it. I think that frontier is a little less worked out at this point in time. For us, in my mind, the most valuable 3D echo imaging is the mitral, which is kind of lent it to be a 3D transesophageal technology. But for tricuspid, for aortic valve, things that we see easier from a transthoracic perspective, I think that we should be pushing that frontier and figuring out what we can find out from that technology, as opposed to just saying like, well, I don't know what the value is because we haven't been there. So the question is whether we can do clips for the tricuspid valve. So that is currently investigation. And no FDA approval for that. A request from Martha to email her if you did not RSVP so she can register you to the folks out there. Okay. Are you in any clinical trials right now is the question. So we are not doing any aortic trials here right now, but my goal is to get that started here. So if you have a specific patient or trial question, I could help direct that. And then if it's something we can do here, we'll also be happy to help.
Or on text or email.
Okay. Well, if there's any more questions, or if people have any aortic or transcatheter therapies, that's my contact info. Feel free to reach out. And I really appreciate everybody for showing up and being on WebEx and Zoom and bearing with us for any technical issues that we encountered along the way.